Viswanath to take the class for us. She is a palliative care physician working with Department of Palliative Care in Hobi Baba Cancer Hospital and Research Center, Visakhapatnam. She is a national faculty of Palliative Care Association and a very dear friend to Pallium India. We invite you, ma'am, to take the session for us.
Thank you so much for that introduction. Is Sunil there with you?
No, ma'am.
Why?
Thank you.
Hi, can I see Sridevi there? Oh, hi. Hello, Sridevi.
Hi.
It's nice to see you. How many participants are here? I can only see about 4 or 5.
I think supposed to be, there are supposed to be 20.
Okay, I can see 10. Yeah, I can see 10. Okay. All right. Yeah, I can see about 10 participants. That's nice. Today's session, can I have the slides too, please? Yeah. Today's session, we start from where you have left, where it has been left behind last time, which is the WHO step ladder. So today we will be discussing mainly about the third step in the ladder, which is opioids in cancer pain, and focusing mainly on the step 3 opioids. Next slide, please. So we have the morphine is derived from, which is a poppy, opium or poppy. It's an alkaloid which is derived from there. We produce it in India, sadly, and we export it. But when we need the drug, most of the times we are unable to get it. So the whole idea in educating you and this session today is to emphasize the importance of morphine in cancer, especially in pain and especially in cancer pain. Next slide, please. Now, this is a case history. The next slide. Is there a way that I can move these slides myself? Okay, go on to the next slide, please. Next slide. This is a 56-year-old man. He has carcinoma of the larynx. He has severe pain around his neck. 10 on 10 is the pain score. It is a sharp pain. There is no radiation. And he has been unable to sleep since the last 2 weeks. So any of you, can you tell me what kind of pain you will classify this as? So what kind of pain will you classify this? Any of you? So would you call it, you have done types of pain, right? So would you call this as nociceptive pain or neuropathic pain? This is, they have done nociceptive and neuropathic pain, right?
Yes, ma'am, they have done.
You have done, okay. All right. So this is nociceptive pain, and this is 10 on 10 throbbing pain, very typical of cancer pain that we see. So this person has come into your OPD. So how are you going to manage this person? The next slide, please. And the next, the one after this. So what we do here is, you can put in everything because it's difficult for me to say next, it breaks my sequence. Yeah, thanks. So in a patient like this, what do? We give something called as an intravenous morphine trial, because we understand that this is nociceptive pain. We understand that he has to be given morphine, but how much of morphine do we give? And how do we assess what will be his dose? For that reason, we have something called as a morphine trial. So ideally, if you want to give it, it's an intravenous morphine trial. So what we do is 1 ampule will have 15 milligram of morphine. So 1 ml will have 1.5 milligram when you dilute it. And so you first give them injection metoclopramide, which is 10 milligram. Then give 1 ml, that is depending on your dilution of morphine, which contains 1.5 milligram of the drug, and go to the end point. Next slide, please. So this is how you monitor. His pain score was 10. And you gave him 1.5 milligram of morphine. He was not drowsy at that time. At 10:10, that means 10 minutes later, you wait for 10 minutes, you ask him his pain score. Now he tells you it is 7, and he's still not drowsy. So go ahead with the next ml. The next ml would mean another 1.5 milligram, which has now brought down his pain score to 4, and he's still not drowsy. So you go ahead and give the third 1.5 milligram. So in total, you have given 4.5 milligram, and at the end of half an hour, his pain score has come from 10 to 1. Once this has been done, then, and the patient is not drowsy, you stop. Now, this has been the intravenous dose. So how do you calculate what is the oral dose? Next slide, please. Whatever is the intravenous dose in milligrams that we have given the patient becomes the 4th hourly oral dose of morphine. So we have given 4.5 milligram IV, and that has brought down his pain from a score of 10 to 1. So now orally, we will start him on, next slide please. We will start him on 5 milligram 4th hourly. So please make sure that the instructions are written over there. So when he wakes up, usual time is 6 a.m. So we tell them, just take the medicine, and if you want to rest for a while, you can continue to do that. So keep the 4th hourly dosing. So 6 a.m., 10 a.m., 2 p.m., 6 p.m. And at bedtime, you have to double the dose. Why do we double it? Because at 10 p.m. bedtime to morning 6 a.m., we have a gap of 8 hours. Otherwise, they will wake up in the middle of the night with pain. So make sure that all these instructions are told to the patient. It's easy to write Q 4th hourly, but it's very difficult to follow and very difficult to make someone understand. So it's important that we emphasize that the drug is given every 4 hours. It is given by the mouth. And the most important is the last column. What does the last column tell us? It says SOS, which means breakthrough dosing or rescue dosing. Why is that important? Because this is for the baseline pain, but the patient may have pain in between. He may have pain as his disease progresses. So to overcome that, SOS dosing is mandatory. You have to tell them that whatever is your 4th hourly dosing, the same dose, please don't hesitate to take it whenever you have pain in between. But also important to add is, do not change the timings. So follow these timings and add the SOS dose whenever needed. That is what we need to explain to them. Next slide, please. So whenever we give now usually in the OPDs, it's not possible to give an IV trial to every patient who comes in. So what do? We give oral morphine trial. So if someone has come to you and has never taken an opioid before, we start with 5 milligram. So we give them a dose of 5 milligram. We tell them to wait for about 40 minutes and then come back and tell us the pain score. So this is how we give the oral morphine trial. We also add Perinom to it and then give them the oral morphine trial. Suppose someone comes to you and he has already taken Tramadol 4 times a day. He's already on Tramadol 4 times a day, 50 milligram 4 times a day. That means he already has crossed the 5 milligram 4th hourly dose of morphine. So in those patients, you can start with 10 milligram. Otherwise, usually in the OPD, we start with 5 milligram in an opioid naive person. Next slide, please. So now our patient was started on 5 milligram 4th hourly. He was pain-free for 2 weeks, all right? But now he tells you that I need 4 SOS doses of morphine per day for the last 4 days. So what shall we do? Anyone among you can answer? See, this can be an extremely boring class, and that too on morphine and absorption. If none of you are going to answer anything, it's going to be very difficult. Any of you, please tell me. What do you think you should do? If the patient comes and tells you, I'm taking 5 milligram at the timing that you said, and I'm needing 4 SOS doses. So what does that mean? What is it telling you? Anyone? Shall I call out names otherwise? If none of you all are going to say anything. How about Dr. Mohan? Dr. Ammalu Mohan. Yeah. Please answer. I think you have not, yeah, you've unmuted him. Yeah. Tell us. What do you think you will do? Is anyone able to hear? I can see her microphone is not muted, but I can't hear her.
Hello?
Yeah, hello, tell me.
Maybe he should increase to 10 milligram.
Yeah, so very good. You have to increase to 10 milligram. You said the right thing. Next slide, please. So how do we do that? What is the principle behind that? So what we usually say is that when 2 or more than 2 PRN doses are taken, you increase the dosage by 30 to 50% every 2-3 days. All right. So what you said was right, because we had taken 4 PRN doses, it will come to a doubling of the dose. So make them write this down, review with the patient, and follow this dictum that when someone is taking 2 or more PRN doses, you increase the dose by 30 to 50% of whatever dose that the person is taking. Next slide, please. So how frequently would you give SOS doses of morphine and why? Next slide. The next slide, yeah. So this is where the pharmacokinetics of morphine is important. What do we mean by pharmacokinetics? It means what the body is doing to the drug, right? So when you're taking a drug, what the drug is doing to your body is the pharmacodynamics. But what the body is doing to the drug is the pharmacokinetics. In morphine, why are we so strict about 4th hourly dosing? Why are we so strict about PRN doses? Why do we do all this calculation? We do it with all drugs. But here, if we understand the pharmacokinetics, it helps us in telling our patients. So that is why the absorption, distribution, how this drug is metabolized and how it's excreted is equally important to learn. Next slide, please. So when the drug is taken, so that oral tablet that you gave Mr. X, he swallowed it, it went into his GIT, and then it got absorbed into his blood vessels. It covered the first pass hepatic metabolism and then went into the systemic circulation. So he has taken X amount of the drug, but how much of it is absorbed? How much of it is bioavailable? That is what we're going to see now. And usually, the next slide, please. So the metabolism is in the liver, a small part of it is in the GIT and in the kidneys, and you have 2 metabolites which are very important in morphine, what we call as M3G and M6G. So M3G is the morphine 3 glucuronide and M6G is the component which gives pain relief. So now you see those percentages, how much percentage goes as metabolites, how much of it forms M3G and how much of it forms M6G. Next slide, please. And it is the upper smaller bowel where morphine gets absorbed. And it is a hydrophilic drug, which means what? That it will happen slowly and it will stay for a longer amount of time. So why is this important? Because our patients come to us with different problems. Suppose a patient comes to us with an ileostomy. Suppose a patient comes to us with intestinal obstruction. So these are the things that we have to think of then. Then giving him oral morphine will just allow the tablet to come out of the ileostomy bag, or it will never get absorbed. So on paper, you will document that you're giving so much morphine, but the patient will still have pain. Why? Because the drug is just not getting absorbed. So it's important to understand that this drug gets absorbed in the upper smaller bowel. It will get absorbed slowly. It will go through the liver and then it will enter the systemic circulation. Next. And that is the reason the subcutaneous and the intravenous routes will be way faster. Sublingually, the absorption is low, though many a times, and even in the buccal and gingival mucosa, sometimes we do tell the patient, crush the morphine, mix it in honey and put it in the mucosa. It will get absorbed, but it takes about 6 to 9 hours for that to happen, and it has a better taste. So that is why we say mix it with honey. So the reason we say these things is because we are following the science behind the absorption of the drug. Next slide, please. Intravenous is a very effective route. It is because the availability is 100%. You eliminate the first pass hepatic metabolism. So that is why when a patient came to you with a 10 on 10 pain score, no medications, screaming in pain, nociceptive pain, our first thing would be to give him an IV trial dose of morphine and give him morphine trial and set his dose. Next slide, please. So bioavailability means the percentage of administered drug which has access to the systemic circulation during oral administration. So like we said, a person is taking the tablet, it goes into the GIT, goes through the liver, then goes from the portal to the systemic circulation. So what is left in the systemic circulation is what is the drug, which is called, is the bioavailability. Next slide, please. So the reason I'm saying this is that absorption and bioavailability are not the same. And there is something called as controlled release preparation. When we say controlled release preparation, many a times we see patients who are given controlled release preparation and those patients are on a rice tube. Or most of the time they are crushing the tablet and swallowing it. So please remember, do not put any of your patients who are on a rice tube on controlled release preparation, because the minute you break the drug and the minute you crush the drug, what are you doing to it? You're making it an immediate release preparation. You are removing the coating which was on it, which was the reason why the drug was going to act for 12 to 24 hours. And there's something called gastrointestinal hurry, which means, like suppose the absorption from the small intestine is going to take unduly long because the patient has intestinal obstruction. Or there is a reason he already has a stoma surgery done. In all these patients, it is not advisable to give them a controlled release preparation, because that area of your body is not going to do its work. So this tablet is not going to work as a controlled release preparation. So it's important to choose the kind of preparation that you want. Next slide, please. So that is why we have aqueous solutions of morphine, we have tablets of morphine, and we have injectable morphine. Aqueous solutions, unfortunately, I think is available only probably in Kerala and in Bangalore. I have not heard it anywhere else. In our parts, we do not get aqueous morphine. We only get tablets and we only get the injectable form of morphine. And in the tablets, we have both the immediate and the controlled release morphine. Next slide, please. So now our friend Mr. X, his dose increased. He was on 10 milligram morphine 4th hourly for the last 6 months. Now he came to you and you found that he was drowsy. Okay. When you find that a patient who's taking morphine comes to you with drowsiness, what are the thoughts that cross your mind? I need an answer for that. Any of you? Before we even go to the fact that his creatinine was 5 milligram per DL, what are the causes of drowsiness in a patient who has come to you? He is also on oral morphine and he's a cancer patient. Yes. Jyoti? Would anyone like to answer this? Yeah, Jyoti. Any of you? Yeah. So why is your patient drowsy? Yeah, could be.
Jyoti, you can speak.
Yeah, you can speak. So why is this patient drowsy? He's on 10 milligram 4th hourly for the last 6 months. And today he has come to you and he's drowsy. Why? What are the things that you will think of? It can be due to overdosage. I can read you. Yes. Then what else? What else? Any other reasons for drowsiness in a patient who's also taking morphine? See, 2 things I would like you to remember is, or before you blame morphine, always think of other causes of drowsiness also. All right. It's very important to keep track of drowsiness, because we keep telling our patients, many of our patients take chemotherapy simultaneously. So when chemotherapy gives them pain relief, automatically we tell them that watch out for drowsiness. In case you're getting drowsy, we may have to decrease the dose. So it's very important, like what you just mentioned, that we should not go over the dose of morphine, because that will cause drowsiness. But always at the back of your mind, keep in mind the other causes of drowsiness. So what are the other causes of drowsiness? You could have brain mets. You could have low sodium. You could have hypercalcemia. So you can have metabolic issues which can cause drowsiness. You can have sepsis which can cause drowsiness. You could have tumor progression. You could have CNS mets. You could have leptomeningeal mets. You could have morphine. So all of these things you should think about. In addition, two of our systems, the hepatic as well as the renal, both these systems, when they fail us, we are going to be drowsy. So it's important to keep in mind all these factors, especially when your patient has a HCC or if he has liver mets, getting drowsy. If your patient is a patient with CS cervix, and then she starts coming to you with drowsiness, immediately suspect the creatinine. So your serum bilirubin, serum creatinine, all of these are also important things that you must think about. So in our Mr. X, what did we see? We saw that he had a serum creatinine of 5 milligram per DL. So what did we do next? So that brings us to excretion of morphine. So what is it that now we went to absorption, we went to bioavailability of the drug, how it gets metabolized in the body. How does it get excreted? By glomerular filtration. So what happens in renal failure? In renal failure, you have the N6G, which is accumulating. So once that starts accumulating, your clearance is decreased. And for Mr. X, what could we do then? We now know that this is the reason why he's getting drowsy. But can we stop the morphine completely because he's drowsy? Would you like to do that? Will it help him? So I don't think that would help him because his pain would remain. So what we could do is we can try, the first thing that we do is switch opioids if possible. But in our country, most of our patients are below the poverty line. And if we have to tell them to switch to fentanyl, it becomes a very expensive option. So though the ideal option would be to switch to fentanyl, the second option would be to increase the spacing. So instead of a 4th hourly dosing, we make the dose 8th hourly. So you make it a TID dosing. Try and go a little lower on the dose. You add adjuvants, add something else for his pain and see if you can help that work or switch the opioid. Next slide, please. So now now the same Mr. X was sent home and he was taking 10 milligram morphine every 4 hours. But he came to you after 2 months, the family brought him and he was already, he was unable to swallow anything they told you. Even the tablet, it's not possible for them to swallow. So then what would you do for pain relief? Next slide, please. So this brings us to the different routes of administering morphine. So how do we administer morphine? By the clock, by the mouth, by the ladder is what you have learned, right? So that is the best way to give morphine. But there will come a time when a patient will not be able to swallow the drug. So if the patient is not able to swallow, we have to find alternate routes to supplement the drug. So how do we go about that? If you are willing to admit the patient and if it is possible for you to admit the patient, the ideal thing would be to convert him to a subcutaneous or an intravenous route. We could also switch the opioid and put him on a transdermal patch, but again, affordability becomes an option. Sometimes when the patient is towards end of life, we also use the per-rectal route. You can also give epidural and intrathecal morphine. But in our practice, the most common routes that we follow are the intravenous, the subcutaneous, and the oral routes. Next slide, please. So this brings us to a fact. I kept telling you we switch the opioid, we switch the opioid. So when we say we switch the opioid, what do we mean? It means that in our country, we do not have a big range of choices to choose opioids. We have to choose between morphine and fentanyl and now methadone. So choosing the opioid, how do you know which patient merits which opioid? So suppose you have Mrs. X. She's on 50 milligram Q 4th hourly morphine. She has now come to your clinic with pain crisis, severe pain. The family has brought her in. You have injection pentozocan in your hand, Spotwin, and you have your oral morphine tablet. What would you like to use? How do you decide? You have Mrs. N. She has breast cancer and brain metastasis. She has received radiation to the brain. She has moderate pain on her breast. What opioid will you choose for her? How will you manage her pain? So how do you make these choices? Anyone would like to answer any of these questions? Or you can even type in your answers. I can read it on chat. So if any of you would like to say how you would like to manage these patients, any thoughts? If you have a patient who's already on morphine, severe pain, you still have the tablet, you have pentozokin, what would you prefer to use and why? First question, time of action is important. That is what Jyoti says, very true. So you now have to give her immediate pain relief. I agree with that. And choice of drug? So how do we choose? The next slide, please. So when we say opioids, it's a general term, right? So naturally occurring is like morphine. Synthetic drugs are like methadone. So they combine with what we call as opioid receptors. All right, next slide, please. Next slide. So you have these three receptors which are important, which is the mu, the kappa, and the delta receptors. All right, so this is found, yeah, you can go to the next slide. These three receptors are found in different parts of the brain. They are found in several areas of the brain, and they are found in the spinal cord and in the peripheral nervous system. So when you gave that tablet to Mr. X, what exactly happened? That tablet, that morphine, the bioavailable fraction of that morphine went and got attached to the opioid receptors, right? And this is what causes pain relief. So when you tell your patient, you always tell them it's the perception of pain that is not there because they're getting attached to the opioid receptors. Next slide, please. So when you choose a drug like codeine, you find that it is 1/10 as potent as morphine. One of the metabolites is codeine 6-glucuronide. The bioavailability is 40%. Onset of action is 30 to 60 minutes. So will you choose codeine for this patient? Duration of action is 4 to 6 hours. I don't think codeine has any role for this patient, right? Next slide, please. Codeine is mainly used when you want to have it as a cough suppressant or an antidiarrheal. And in the body, codeine forms morphine. So we do not really have codeine on our list of choices unless we want to give it as a cough suppressant. And cough suppressant, and today it's not even available everywhere. We also have dextropropoxifen. Next slide, please. I'll go straight to, yeah. Then we have this drug called tramadol, which all of you see. And this is like a bridge between step 2 and step 3. It has a very high bioavailability orally, but the reason why we have to think before we give tramadol is it lowers the seizure threshold. And the dose limiting side effect is nausea. It takes 4 to 6 hours to act. And when someone is already on morphine, you will not really want to add tramadol to that patient. Next slide, please. Fentanyl is the opioid that we have, and here the preparations that we use are the transdermal preparations. It is a lipophilic drug. And next slide, please. The transdermal patch forms a depot, and it provides effective analgesia after for 8 to 12 hours, and it lasts for 72 hours. So when you stick on the patch, everybody knows that it lasts for 72 hours, but we always forget that the analgesia starts after 12 hours. So when you are switching someone from morphine to fentanyl, you have to cover those first 12 hours. You can't just tell someone, okay, this is put off the patch and then, take the patient home. It doesn't work like that. You have to first convert oral morphine into the requisite dose of fentanyl. And then once you stick on the patch, you have to explain to them that the first 12 hours, the patch will take time to act and it forms that depot. Till all that happens, you have to take your regular oral morphine dose. 2 more things for fentanyl is, one is if a patient is extremely cachexic. The patient is extremely cachexic and has almost no fat under the body, this drug may not work as well. Second thing is if the patient is febrile. If the patient is really febrile, sweating, this drug again may not act. So choosing your opioid is very, very, very important. It is not like this didn't work, so I go to the next. It doesn't work like that. Next slide, please. Buprenorphine is another drug that we see here. Buprenorphine, very, very often we have patients who come to us stuck with the buprenorphine patch stuck on them. Unfortunately, buprenorphine is a different kind of drug. It's the way it binds to receptors, which you will see in the next slide. It has what we call as a ceiling dose. And this is the ceiling dose means after a particular dose, the drug will not act. You can keep increasing the dose, but it will not have any effect on the pain. Next slide, please. So we need what we call as equipotent doses. Equipotent means like codeine is 1/10 as potent as morphine, tramadol is 1/5, and between the oral, subcutaneous, and intravenous morphine, it is 1:1, 1/2 to 1/3. So what does this mean? This means that if a patient is on 200 milligram of tramadol, okay, every day, the starting dose of morphine would be 1/5 of that. It would be 40 milligram of morphine per day. So this gives you a mental idea. That is what is meant by potency. And suppose a patient is taking oral morphine up to 60 milligram a day. You want to convert it into the subcutaneous route. What will you do? You will halve the dose. Because remember, bioavailability increases if it is subcutaneous or intravenous. So whatever is the oral dose, you make it half, that becomes the subcutaneous dose. You make it 1/3, that becomes the intravenous dose. So when you're changing your route, you should also change the amount of drug that you are giving them. Next slide, please. So when we say potency, there is something called efficacy, there is something called potency. Efficacy means I'm giving the patient morphine. What is the analgesia achieved after I escalate the dose? Is how efficient or what is the efficacy of the drug. Potency is how much of this drug enters the systemic circulation, how much of it binds to the receptors, and its affinity to the receptors. So you can have two drugs which have the same efficacy, but they will have different potency. Means both the drugs will give you the requisite analgesia, but their potency will be different. So that is why fentanyl is more potent than morphine. Morphine is more potent than tramadol. Next slide, please. So that is why we classify our opioids based on their receptor interaction. We call them agonists, we call them antagonists, or we call them agonist-antagonist. Why is it important to know this? Next slide, please. Because agonist is like morphine. It is a drug which has an affinity for the receptor and it will induce the change. And it has no ceiling effect. You can keep on increasing the dose of morphine till the pain comes under control or you get side effects. Next slide, please. See, this is how the log response curve will be. It is a linear curve, which means as you increase the dose, you will get better analgesia or the dose limiting side effects will come away. Next slide. So the different agonists that we have are morphine, codeine, fentanyl, tramadol. All of these are agonist drugs. Next. When we say antagonist, it means that it will go bind on that receptor and interfere with that agonist. So it will bind for that receptor and interfere with it. Next slide. So here we have naloxone and naltrexone. So when someone has opioid toxicity, we use naloxone. So what does naloxone do? It goes and binds to those receptors, and thus we bring back the patient from toxicity. Naltrexone is used for constipation also. It's in fact combined with drugs and it can be used. When we say agonist, antagonist, these are the things that I want you to listen to carefully because these drugs have a ceiling effect for analgesia. When I was mentioning about buprenorphine, this is a partial agonist. So these drugs, though they produce analgesia, they are agonist at one receptor and antagonist at another receptor. Next slide, please. So this brings us back to pentozokin and buprenorphine. The question I asked you right in the beginning, when your patient was on 50 milligram morphine and that patient came to you with pain, you had a choice between giving that patient pentozokin injection or a better drug, what would you choose? Reason I would not choose pentozokin is this, because it has an agonist antagonist action. Next slide, please. So this is what it will do. It will bring down my level of analgesia. Next slide. Because pentozokin has an agonist action at the kappa receptor and it has a weak antagonist action at the mu receptor. Now, mu receptor is where morphine is the agonist. So all the good work done by morphine will be nullified by pentozokin. So now you realize why you shouldn't mix drugs which have an agonist antagonist action with a pure agonist. Because it may be very tempting to give that patient pentozokin and give him immediate relief and send him, but he will become more drowsy. His level of analgesia will come down. And what you are doing is, instead of working on the pharmacology, you're actually breaking it apart. So your pentozokin will go there and it will remove the good effect of morphine. So instead, what will we do for our patient? We will again put them on the trial and we will again upscale the dose of morphine if it helps, or add adjuvants if that helps. So that is the answer to your first question. You would not go with injection pentozokin. In your second question, when your patient had brain metastasis and she had moderate pain, and you were always taught that in moderate pain, we can start with step 2, yes or no? So would you give tramadol to this patient, though she has moderate pain? Yes or no? Would you give tramadol to that patient with breast cancer and brain metastasis? What is the one thing about tramadol that you should keep in mind? Yeah, you wouldn't give. Very good, Jyoti. So why wouldn't you give tramadol? Yes, because it lowers the threshold for seizures. So your patient might get pain relief, but you are lowering the threshold for seizures. So usually in our patients who have brain metastasis or disease in the brain, we usually avoid tramadol and we go straight away to step 3, even if the pain is moderate, or we try and use NSAIDs and paracetamol. Next slide, please. So now we've spoken about all the good things that morphine does. We also have side effects. And the side effects with therapeutic doses is something that you should be completely aware of. The most important side effect, which will never ever go away, is constipation. Don't ever forget that. If you are prescribing morphine, that hand should prescribe a laxative. And don't think that, oh, the patient is not eating, oh, the patient, don't excuse yourself for that. You have to give them a laxative, and do not just write any laxative like lactulose or isabgol or something like that. You have to give them a good stimulant laxative. The next adverse effect would be nausea, vomiting, but nausea and vomiting is usually self-limiting. So for the first couple days, if you give them a good antiemetic, especially aprocan, and if you give them metoclopramide or haloperidol, patient starts feeling better. Sleepiness and tiredness also can be self-limiting. Itching is one adverse effect that a patient, if they have, it can go after some time, but sometimes it can be very intractable. And in that case, we might have to switch opioids. Next is dry mouth. Yes, this is an effect of morphine that you can't do away with. So you have to teach the patient how to get around the dry mouth by sucking on sweets, by sucking on ice cubes, by drinking and taking small sips of water, keeping themselves well hydrated. These are the other ways that you can work around that. But constipation, you can never work around. Next slide, please. So like I told you, you have to give them a good stimulant laxative. So we prefer to give them bisacodyl. You can give them bisacodyl. You can give them cremafen P, that is liquid paraffin with sodium picosulfate. So a stool softener and a stimulant. You can use combinations, anything that helps them to have a proper motion. And one more thing that you should bear in mind is when you take history of constipation, don't just ask them, did you pass motion? They will say yes, and they will stop. Ask them the consistency of the stool. Is it hard or is it soft? And what is the quantity? If they say small amount of hard stool, it means that a lot of the stool is left behind. And many a times we have actually seen patients coming with symptoms which look like an obstruction, but it's actually long-standing constipation. So every single visit, if you take that extra time to do that, then this complication need not be there. Next slide, please. Vomiting and nausea, like in the first few days. Next slide. So the drugs of choice that we use are those which act on the chemoreceptor trigger zones. So the haloperidol, metoclopramide, and domperidone are the drugs of choice. Please don't be tempted to give them Ondem. Ondem will not work, though I know that everyone writes Ondem first or Ondansetron first, or even if you don't write it, the local pharmacy will give it to them. So explain clearly and tell them not to take Ondem and take these drugs, because this is what is going to help for morphine-induced vomiting. Next slide, please. This is a self-limiting symptom. Next slide. Now, what do we call as toxicity? Toxicity means that when you are giving a dose which is higher than what is required, if there is some damage to the brain, think whether it's end of life. So there are many, many reasons for delirium. So rule them out and then think of morphine also if the patient has come to you with that. Myoclonus is another effect, and this is dose dependent. The patient classically comes and tells you, I get jerks. And we had a patient whom, if the dose went up beyond 30 milligram, he would invariably come back with myoclonus. So though it was for a very long term, we had to switch this patient and we had to put him on fentanyl because there was no other way of surmounting that. Next slide, please. Now, this is something which all your textbooks teach you, and being fresh graduates, fresh undergraduates, you will all think morphine produces respiratory depression. But this is one myth. If this is one thing that you learn at the end of this class, that morphine does not cause, oral morphine tablets, when used for pain, titrated to the right dose, does not cause respiratory depression. If this is one lesson you learned from today, I will be really happy. Next slide, please. So when you have respiratory compromise and your patient is on morphine, please think of other things. Think of pulmonary embolism, pneumonia, or anything else. Or think of co-medications, like you're giving that patient another benzodiazepine. Don't think of morphine and stop that morphine first. Next slide. And addiction is another thing which is a very misused word. Because when you say addiction, it is actually physiological addiction, substance abuse, and there is a lot of confusion in terminology. What you might mean to say is what we call as physical dependence. So when we say addiction, it's actually the psychological dependence. So suppose my patient is taking chemotherapy, his pain is coming down and he is drowsy. That means then I start decreasing the dose of morphine. How do I do that? I will not stop it overnight. What I will do is bring it down by 75% first, and then bring it further down by 75%, and then gradually stop the drug. Because by then he would have developed what I would call a physical dependence to morphine. That is not called an addiction to morphine. Next slide, please. Next slide. So addiction, when you define it, has genetic, psychosocial, and environmental factors. And it means you do not have control over that drug use. You need it compulsively. You will use it even if it harms you. You will develop a craving for it. All these are the criteria for addiction. And I don't think in our practice we ever see patients who are addicted to oral morphine when given for pain. Very, very few. Next slide, please. So what we mean by, what you probably have in mind by addiction is what we call as physical dependence. So if you suddenly stop the drug, they go into withdrawal. They may even start having lacrimation, more increased sweating and all that. So that is what we call as physical dependence. So to avoid that, we gradually bring the dose down when we are tapering morphine. And so like what we keep reiterating, that we have a Cochrane review also, which says that iatrogenic opioid addiction is really, really rare. You can have adverse effects, but serious adverse effects in addiction, very, very rare. Next slide, please. And yes, coming to the cost of morphine, it is one of the cheapest drugs in the market today. So that's why I think no pharmacy will even want to support it. Next slide. Just one last slide about methadone, because we were discussing step 3 opioids and we can't leave out methadone. Methadone is a synthetic opioid. Till 2007, we were giving it till 2007 in our country, it was allowed, in 2007, it was allowed for de-addiction. But from 2016, we can now use it for pain relief. And it's very important because this is a synthetic opioid. It's an opioid agonist. It's an NMDA receptor channel blocker. It also is a presynaptic blocker of serotonin reuptake. So all these properties together make it a very, very effective step 3 opioid. But when do we use it? The indications would be when patient has toxicity with morphine, when there is complex pain, when there is renal failure. Because we keep converting doses from morphine to fentanyl, tramadol to morphine very easily in our minds. We do it all the time in our practice. But for converting morphine into methadone, it needs training, because the equivalence of the drug is not very simple. So the dose titration needs training, and this training, you have to actually train, you have to admit the patient for about a week, and then gradually you use different methods, and then you switch the patient from morphine to methadone. So right now, you have very few centers in our country which have methadone. And one more thing that we need to keep in mind is this drug has a lot of interactions. It can cause electrolyte disturbances and some fatal side effects. So that is the reason, though it's a very good drug and we need to train ourselves to use it, you need to be cautious when you're using it. Next slide, please. So some of the things that can come up for discussion if you have not developed toxicity to my talk, because it's been non-stop for the last 40 minutes with hardly any interaction. And now I would really require some voice rest, and I would like you to ask some questions if you have. And these are the things that you need to discuss. Like if a patient is on 4th hourly morphine, what will be his daily dose? How would you convert it to a sustained release morphine? If you wanted to switch him to fentanyl, how would you do it? What do you mean by breakthrough dosing? And if he needed an alternate route, how is his dosing be? So these are the thoughts and things that you can bring into your discussion. So thank you very much for that very patient hearing. And I would welcome questions, please. Sridevi? Time for you to take over.
So like last time, I don't accept any silence this time. So we have to come up with questions. Or I presume that you understood everything about opioids.
Which is hard to believe.
Still, I'm on the learning process. So please.
Yeah, there is a question there. If suppose a patient took morphine 10 milligram Q4 hourly and 20 milligram HS. Yeah. So what is it about that? Ask the question.
Okay.
I wanted to know the IV dose to be given. Okay, Sridevi. Yeah, you can.
It's for you, Vidya.
Yeah, can anyone answer? 10 milligram 4th hourly dosing. So 20 milligram is his ordinary HS dosing. So now tell us what will be his IV dosing.
Any calculation, any guess?
Any calculations?
I think Amar, you have to unmute yourself.
Yeah.
Please.
Yeah.
3 milligram.
Yeah. So how did you get to that figure? Go step by step.
I have to take 1/3 of the dose he is taking.
Yeah. So what is his daily dose?
10 milligram.
10 milligram is how often?
4th hourly. So I can take 1/3 of 10 milligram. Okay, IV dose is given 4th hourly.
So what is the easier way to do it? Whenever you're calculating doses, first calculate the 24-hour dosing. So what is the 24-hour dosing? If you said 10 milligram 4th hourly, what is the 24-hour dosing? Hmm? So we have 24 hours in a day. Every 4 hours, you're giving him 10 milligram morphine, right? So if you want to calculate how much you give that patient in 24 hours, what will you do?
I'll multiply it.
Yes, right?
It's 6.
Very good. So what did you get as your daily dosing?
60 milligram.
Excellent. So now you know that this patient is receiving 60 milligrams of oral morphine in 1 day, right? Everyone clear till there? 60 milligram oral morphine in 24 hours. So now you want to convert that into IV. So what will you do?
Okay, 1/3 of 60 milligram.
Yeah, right. Okay. So once you do that, then so to keep it as a constant, we always use the 24-hour dosing. Okay. Sri?
30 milligram would be the total dose for the day. So according to the duration of action, as you said, you can divide it into 6 doses, or you can even give it as a continuous measure over 24 hours for pains which are not very stable. Suppose patient develops pain in between irregularly, not a breakthrough doses. And if you want a sustained pain relief over 24 hours, the same dose can be given continuously over 24 hours. To confuse you much more.
So any more questions?
If you can't ask in time,
Can I give 20 mg?
generally not. It's a too big dose to give as a bolus. So it has to be. So how did you like Jyoti? How did you come up with the 20 milligram IV stat? I did not understand. Is it by 60 milligram? Is a total oral dosage. That is over a day, she will be taking 60 milligram oral morphine. And you are converting it into IV, it comes to 30 milligram. That is over a day, not a single dose. Not 30, 20 milligram, over a day. So that should be divided, not a
So
single.
yeah, so make sure that that dose is divided over 24 hours. All right. It's not a stat dose. It's over 24 hours. So like how you calculate for your IV, you calculate into your CSCI, you calculate into your pump, or you calculate in the drip as per so many drops per minute. All right, after diluting it. But don't, that is not for, not a bolus dose.
Anyone else, you can just type it.
I'd like to clarify that myoclonus is not seen in everyone who's taking more than 30 milligram. We just had one patient whom we saw it in our setting, but myoclonus is not in everyone who takes more than 30 milligram. We have a lot of patients taking it. It is the M3G is what is responsible for the myoclonus. So it happens only in some patients. But why we need to know is that you have to be watchful. And if someone comes and tells you that I'm getting these jerks, don't dismiss it off. Think that it could be myoclonus due to morphine. All right. Am I clear with that, Amalu?
The dosage varies from pain to pain and person to person. So, so that it's time to. I think it's time to move on to the case. So, okay, how much is the maximum stat dose? Do you mean oral or systemic? But whatever, oral or systemic, stat dose maximum is according to the patient's pain. You have to titrate it. Generally, the titration is very slow, as Dr. Vidya was mentioning, how we do the IV titration. It should be 1.5 milligram of morphine intravenously or subcutaneously every 10 minutes. So you are gradually titrating it up. every 10 minutes you are watching the patient, whether the patient is developing drowsiness or mindfulness. Generally, the drowsiness comes first. So you keep watching the patient every 10 minutes. Before the next dose, we will assess the drowsiness, we will assess the respiration and blood pressure. Then only we will give the second dose. So generally, at a time we give 1.5 milligram, maximum of 3 milligram. I have not gone beyond that. And for oral, we start with 5 milligram for a patient who is on opioid for the first time, or even 10 milligram can be given, but generally for monitoring purpose, we give 5 milligram and then monitor, and then you decide whether you want to give more doses. So it's not a loading dose that you are giving, which will be like some other drugs. You have to titrate it very slowly and very carefully.
So we can move towards a case presentation now. Can we? So over to you, Shrita. You can start.
Am I audible?
Yes.
Yes.
Good afternoon, ma'am. Good afternoon, all. Myself, Dr. Sridhar from Kollam. I've completed my graduation from Travancore Medical College, Kollam. Here I am presenting a case history of a male patient, 60 years old male patient, who is a known case of metastatic non-small cell carcinoma non-small cell lung carcinoma, post-palliative radiation therapy to lung, status day 8 of second cycle of chemotherapy with carbogem that was on 5th of February 2019. Now with acute cystitis. Next slide, please. Presenting complaints. He was presented with burning sensation during micturition and with severe abdominal pain. He was already on tramadol and acetaminophen. He was already on Ultracet tablet for backache, but backache has increased in intensity for the last 5 days. And the third complaint was sleep disturbance, which was due to pain and abdominal discomfort. History of illness. He is a known case of metastatic non-small cell lung carcinoma, post-palliative radiation therapy to lung, status day 8 of second cycle of chemotherapy with carbogem. Next slide, please. He was having a history of UTI for last 5 days and was on oral augmentin and citralca syrup. At that time, he presented with dysuria and neutropenia. Both his blood culture and sensitivity and urine were sterile. Neutropenia recovered with GCSF, that is granulocyte colony stimulating factors, and urology evaluation was done at that time. Advised CT urogram if symptoms persist even after medication. Patient was discharged since he was symptomatically better and counts improved. Now on examination, he was conscious, oriented, bedridden, back pain increases on movements, vitals normal, per-abdomen distended, hypogastrium and right hypochondrium were tender, and dull flanks on percussion. Respiratory system, on auscultation, chest was clear, air entry decreased on right side, then tenderness over lumbar spine and sacrum. Treatment and significant investigations. His urine routine examination was done, showing 10 to 15 pulses. Blood routine examination showed severe neutropenia, and USG KUB showed mild increase in bilateral renal cortical echogenicity. Corticomedullary differentiation is preserved. Evidence of few parenchymal calcifications noted. Urinary bladder showed moderate distension. Diffuse wall thickening with trabeculated pattern noted with multiple internal echoes, suggesting cystitis. Postforwarded residual urine nil. Next slide, please. About his psychosocial aspects, he was very much concerned about his disease, its physical status, and mental depression due to pain and repeated hospital stays and financial burden and his dependency on others for day-to-day routines. Next slide. Medication given there. He was on tab Ultracet TDS. Now it's changed to tab morphine 10 mg TDS and 20 mg at night. Injection graphene, granulocyte stimulating colony stimulating factor given over 5 days. The IV antibiotics, ceftriaxone sulbactam was given. Tab Veltam, which is translucin, given. Then tab tranexamic acid and tabrazo and syrup citralca was also added for supportive care. Main concerns: his abdominal pain and increased backache in association with cystitis, getting settled on addition of morphine, and limitation of mobility due to backache, sleep disturbances due to pain, financial issues due to repeated hospital stays, and mental depression and concerns about his disease. Summary. He's a 60 years old male patient, non-case of metastatic non-small cell lung carcinoma, post-palliative radiation therapy to lung, status post day 8 of second cycle of chemotherapy with carbogen on NSAIDs for back pain. And now with increased backache and abdominal pain in association with cystitis, issues getting settled on morphine, IV antibiotics, and other supportive measures. Next slide, please. And for discussion, Madam, in this scenario, what is the role of adjuvant drugs and what are the adjuvants we can add for this pain management? The second question is, if one's abdominal pain due to cystitis gets settled, and if the increasing pain, back pain, is due to metastasis, what can we do further to help him?
Thank you, Shrita, for the presentation. Is this a patient seen by you?
No, madam, actually. Ma'am,
Yeah. So I think all these questions was kind of answered in Dr. Vidya's presentation. So I would like to get the suggestions from you people. So how to go about the pain management. If you start with the pain management, he is on morphine 10 milligram 3 times a day and 20 milligram at night. And before I forget, I want to tell you that when you present in this kind of scenarios, just go through the detailed assessment of pain. We have learned the pain assessment, so just mention where the pain, what is the pain score, what kind of pain he has, what is the quality of pain, whether there is any radiation. So I think I am not. It's just, yeah. So that has to be kept in mind, just as a reminder for everyone. So how would you go about this? Not only to Shrita, everyone else can pitch in and help her. Does anyone would like to titrate morphine or any other medications to be added? Or would you like to know more about the pain? You can type if you want, please. Why is this patient using tranexamic acid? Would you like to answer, Dr. Shrita?
Maybe due to chance of hematuria due to cystitis.
What about the pain, Shrita? Like he is on 10 milligram morphine 3 times a day. So is his pain responding to morphine? What happens after he takes morphine? Is his pain from 10 out of 10, is it coming down? If so, how much it is coming down and for how long? I am not planning to bombard you with questions, but just to think, like, then only you will understand how far the morphine is helping him. You will understand whether you are giving adequate dosage of morphine, whether his pain is morphine sensitive. Do we need to play around with morphine more before we add on something else like an adjuvant? Or is it clearly an indication for an adjuvant? Just these are the things that you should think before titrating to the next dose or a next medication. I hope Vidya will have some inputs from her side to talk about.
I have exactly like what you said, Shri. The first thing would be assessing this pain. Okay, because you have pointed out a few things here. You're saying that there is a pain in the sacrum, there is a pain in the back, and it's something that you have to think beyond. Do we need something more? Are we blaming everything on that cystitis, or do we have to look into what kind of pain that is? And the question that which can always help is when you give someone morphine, you ask them after 40 minutes how much of your pain has come down and assess the response to morphine. Only then we will know if your pain is completely morphine responsive or not. This patient is telling you a lot of things. He's talking about an increasing backache. You are giving a history of tenderness on the back and the sacrum. I think you've mentioned it in your history. There, it increases on movement, you have said. You have said tenderness over the lumbar spine and sacrum, which is very significant. So what should we do further? That is one aspect which you have to think about. One more aspect I wanted, there was a question which said, why are we giving tranexamic acid? Now, what else could be the cause of that hematuria? You have mentioned clearly that he was neutropenic. He needed GCSF. So could it be that the counts have dropped, the platelet count has dropped, and because of that he's having hematuria? Was that there? Was that thought of? That's one thing. Second thing is, why are you giving him all those drugs? There are two tamsulosins, if I'm not mistaken. Both of them look like the same drug. Why is he getting that? Is one more thing I wasn't clear about. He's getting Weltam Plus and he's getting Rolifo. If I'm not mistaken, both of them are tamsulosin and one is a combination with tolterodine. So why is he getting all that? Did he have something before? Or because usually those are areas where would help with a little more information. So any light on that as to why he's getting those medications? They are alpha adrenergic blockers, but both of them are. And why is he getting two? And why is he getting it at all? And like what she said, Trenexa, if it was because of the low platelet count, then giving them GCSF, giving them the antibiotic, hydrating him well, would have reversed those symptoms. So if that's another question that I had. Exactly, Srita, this is not to bombard you, okay? Like what Sri said, we are just asking you, you're just presenting it, and so you're getting to hear all the questions. But the questions are open to everyone. If anybody can answer, I'd be very happy. Please answer, or whatever you know. Because we know as much as you do right now. And going back to Sri, what you can answer is assessment of that pain and what you think will work.
I think we have learned about the pain assessment, right? We learned about the PQRST. So even after you give morphine, after 40 minutes, you repeat the same thing. You ask the pain score, how much it has come down. So it will give you a clear idea about whether this pain is sensitive or not to opioid. Whether if it is sensitive, whether it is completely sometimes the pain score goes down to 1 or 2, sometimes the pain score will come only up to 6 or 5. So then you will understand, okay, this pain is partially sensitive to opioid, so you may need to add on something else. So only if you assess, give attention to detail after giving medication, then you will understand which medication to play around with.
And what would be the drug of choice if suppose this person said my pain is coming only to 60% and I'm still having that pain at the bones? What would be the drug that could work?
Is it for me or is it open to everyone?
No, obviously not to you, Sri. You can answer too.
And this one thing, when you think about the neuropathic pain medication or adding on any other medication, you optimize the existing medication. You make sure that you have reached a good dosage, correct timings, and you are done with that medication. You have reached that limit. Then you start on. Then you think about adding on to or switch on to something else, like giving morphine TDS. I don't know, like whether you want to increase it or not. Consider it first, optimize it, then you start thinking about adding on. If you are not sure whether that is neuropathic, sometimes we do start with both morphine and some adjuvants. Yes, if you are clear that this is a neuropathic pain and you need some neuropathic pain medication. Even with neuropathic pain medication, try to optimize with one class of drug and then you start thinking about the next. Because very often we see mix and match of lot of medications like anticonvulsants, then there will be a little bit of PCAs, then there will be something else going on for neuropathic pain medication. So we don't know exactly which one is working better, and he'll be taking a lot of medications. So optimize one medication, even in the case of opioids. I'm not sure whether he is getting that dose which he actually needs.
And one more question is, ma'am, can we use an adjuvant drug or an NSAID patch? This is just taking it on from what Sri was saying. One more observation is that you've given morphine, but where is the paracetamol? Are you giving it? One of the most important things that we need here. So I would make sure that, because in ultrasound, the paracetamol was mixed with the tramadol, but when you started him on morphine, did you put him on paracetamol? So putting him on paracetamol itself will bring the pain down. You give him 650 milligram 3 times a day or 1 gram 3 times a day, the pain will come down straight away there. So first add the paracetamol, optimize the morphine to the right dosing. This TDS dosing will not work unless his creatinine is high, and that's the reason you're giving. But if you're giving TDS, then I don't know what that 20 milligram at night is doing. So this is improper dosing time. So first, make the dosing 4th hourly, add the paracetamol. Adjuvants that you can use are probably the NSAIDs and DEXA. And one more thing which I feel you shouldn't miss out in this patient with the history that you've given is to do a bone scan and think of palliative RP. Because the way you're describing that sacral and pain on the spine, he very well could have bone mets. So if he has bone mets, then the first thing that we should do is give him either single fraction or 5 fractions of 20 gray radiation, which will drastically cut down the pain. So these are the thoughts that I had when I saw this patient and this, whether that, one is the bleeding part of it. The second thing is assessing that pain, adding paracetamol, adding an NSAID, going down and doing a bone scan and seeing if palliative radiation will work for this patient. Any other thoughts?
Any more questions?
Any more questions, suggestions? Yes, if it is bone pain, Jyoti, you can add steroids. But again, you have to be cautious because at one side, the patient is just coming out of the infection and bleed. So you have to let that settle. Okay. So that's why paracetamol is the first thing you will have to add if it is not there in the prescription. And then step up. Did you work up this patient yourself, Srita?
No, madam.
Okay.
Actually, I took the details of this case from my friend just to
Yeah. So
present
then
it.
why don't you go back and ask all these questions and get us the answers?
Even I was suggesting, if possible, if there is any chance, you can go back and ask, okay, you are taking
Yeah.
10 milligram morphine. How
Okay.
far you are getting pain relief and how long it is lasting for? Is it for 2 hours or 3 hours good relief? Then you can definitely increase the dosage. And what about the fourth hourly dose? So it will be a learning for you too. If you go and ask again what you have learned from today's session.
All right.
Okay, ma'am.
Yeah. Try to do that and give us a feedback. It'll be nice to know.
It will be,
Okay, ma'am.
yeah, that's a suggestion for everyone. Like last time, Dr. Krishna Kumar presented. So if you don't want to speak up, please send an email to the Tipsico account. That, could you do some suggestions? Could you introduce these things to your practice? And if so, did they bring any bad impact or a good impact? Something if you want to share, it will be a learning for us also. Yes, we all can learn together. So please send your feedback to the Tipsico account so that we'll understand how it is going. Again, silence, breaking the silence is a difficult part in this group.
Yeah. It's so silent. You wonder how many of them actually, are they there or are they not? First of all, it's really hard taking a class and in front of an audience, which everything is on the screen, and a generation which is not used to that. So anyway, thank you, Shri. So I guess,
Madam,
yeah. So,
I have a doubt, not regarding this case.
yeah.
Even now, I have a doubt which all patients are eligible for palliative care services. Even I a patient, a non-case CKD patient for dialysis, uh, will he eligible for this palliative care services?
Sri?
So I hope any life-limiting illness, just put yourself in his shoes and, or just think whether he is suffering due to his illness. The patient you mentioned, like CKD patient, is he suffering due to his prolonged illness? Any kind of suffering. It can be physical suffering. It can be this suffering because he's existing still. It can be suffering because he cannot go for treatment because of financial issues. So any kind of suffering which is related to his prolonged illness, yes.
Water.
Any life-limiting illness, any serious health-related suffering, the answer would be yes for palliative care. So don't restrict yourself to cancer patients.
Okay,
So
ma'am.
like what Sri said, it's any illness where you know that there is going to be cure, where there is suffering, where symptom control can help. That is where palliative care can step in. So it can be with CKD, it can be with liver disease, it can be neurologic, pulmonary, all of these, geriatric, in addition to cancer. So
And for the information purpose, here we cater to more than 50% of patients come under non-cancer diagnosis, including CKDs or liver issues. A lot of patients with stroke who partly recovered or not recovered, so they'll be bedridden. A lot of old age patients without any background illness, just frailty. A lot of pediatric patients with developmental issues. So it comes with all the life-limiting illness.
Thank you.
Amaro, I would suggest they should definitely go for a disease modifying treatment, as in cancer we say disease modifying therapy. So yes, psoriasis, you can always consult a dermatologist. We have patients with psoriasis but with a lot of other comorbidities, and patients who are bedridden with psoriasis, they can't go to a dermatologist and consult and see what can be done. So yes, they do come under, but not all the psoriasis patients come under palliative care. Is it clear?
thank you. Yeah, I'm also done.
Dr. Vidya, I know how
Yes.
busy you are there, and I can't imagine how you took out 1 hour, 1.5 hours out of your tight
No,
schedule.
that's okay. It's always a pleasure to talk to all of you.
Thank you for
Thank you so much.
Thank you so
Thank
much.
you, ma'am.
All right. Thank you. Bye, all of you.
Thank you.
Yeah, bye.
Closing.